Hello, good morning. I'd like to be discussing about rheumatoid arthritis, which is an important illness and is now being treated in an organized way. To do that, we'll need to see how this is diagnosed in the primary care and then eventually in the secondary care, and as to what options are available for its treatment. I hope you're able to see the slide. So, how does one define rheumatoid arthritis? We know already that it's an autoimmune synovitis, mainly affecting small joints, such as in the fingers and in the toes, and to a less frequent extent, larger joints as well. It is also characterized by a degree of remission and relapse, and that it is an inflammatory process associated with most of the other inflammatory characteristics. It is perhaps the most common inflammatory joint condition universally. And in the UK, the incidence involves around 0.5 to 1% of the population. So this means that since screening process and diagnosis process have begun, close to nearly 500,000 people are currently suffering from rheumatoid arthritis, with 20,000 new cases added every year. There is a preponderance in women by 3 times as compared to men, and the mean age is around 50. Rheumatoid arthritis is more common amongst the smokers. It is a complex illness caused by combination of immune cell activities and dysfunctions, release of cytokines, and their interactive damage to the synovial part of the joint. There are also some genetic factors involved as well. The entire process is somewhat confusing and ill understood. And this explains the variety of treatment that is now available on individual basis. It goes on to produce uncontrolled inflammation following exposure to any trigger. And this leads on to involving the synovitis, which shows a chronic inflammatory reaction. And if it progresses further on, then it will end up damaging the intervening cartilages and the surfaces of the joint bones. In reality, when it presents itself, there is usually a symmetrical polyarthritis of metacarpophalangeal joints and proximal interphalangeal joints of hands and feet. It is also characterized by an early morning stiffness of the joints lasting for more than half an hour, or when the person has been inactive, then the stiffness lasting for a much longer time. There is also swelling of the joint. There is an inflammatory heat, and when it involves the finger, one can laterally compress the MCPJ or PIPJ to produce a degree of tenderness when making a fist. Because it's an inflammatory disorder which persists for a longer while, there is raised erythrocyte sedimentation rate, C-reactive protein, and the rheumatoid factor is positive, and there is increase of the anti-CCP antibodies as well. But we must remember that the most linked factor in the diagnosis of rheumatoid arthritis is rheumatoid arthritis factor itself, which may be negative in about 50% of the patients. So not one test will suffice for the diagnosis of rheumatoid arthritis. If you look at this X-ray, you would see that there is a degree of erosion in the metacarpophalangeal joints, such as in the thumb and around here. And also some of it is also present in the region of the proximal interphalangeal joint. There would be synovial thickening, sometimes calcification. There would be effusion in the adjacent area. But these soft tissues are only visible on scans or on clinical aspects. In this case, there is some degree of synovitis of the main wrist joint as well. And if you look at the clinical features, there is ulnar deviation of the proximal joints, such as metacarpophalangeal joints, and of course the proximal interphalangeal joint. And the same applies to the feet as well. And these are fairly symmetrical. And you can see a kind of a degree of hallux valgus and also overriding second toe. And the hallmark would be present in the metatarsophalangeal joints and also in the proximal interphalangeal joints of the toes. Here is a slide which shows synovial fluid and synovium. This is the covering which is thickened and increased in extent, and eventually it would lead on to erosion of the cartilages adjacent to the joints. Here you see ulnar deviation, proximal interphalangeal joint involvement, proximal lesions such as metacarpophalangeal joints. What are the complications associated with rheumatoid arthritis? There is usually anemia of chronic diseases to the extent of 77%, but there would be some degree and in some cases of iron deficiency anemia as well. The orthopedic involvement could lead to carpal tunnel syndrome and rupture of tendons, cervical myopathy, and nodules which are palpable on the surface. Because of the non-specific inflammatory disorder, it also affects the blood vessels, causing vasculitis, and hence it can lead on to non-joint areas as well. There is usually, in complicated cases, some pleural fibrosis and pleural effusion. Similarly, there'd be pericarditis or Sika syndrome. Fentis syndrome is also associated, which is presence of rheumatoid arthritis, splenomegaly, and lymphocyte intense multiplications. There could be amyloidosis of kidneys or other organs. One sees that the infection rate arising from bacterial, viral, or fungal sources are doubled than the person without rheumatoid arthritis. So with which diseases does rheumatoid arthritis remain associated? And so we can see statistically that cardiovascular diseases such as peripheral arterial disease, heart failure, and functional diseases of the heart, anxiety and depression, osteopenia and osteoporosis, GI tract disorder such as inflammatory diseases like ulcerative colitis, Crohn's colitis, and also cancer. It is also known to coexist more often than normal with lymphoma and thyroid cancer. So how does one make a diagnosis of rheumatoid arthritis? Many diagnostic policies are made, but the most prevalent one is that there should be at least synovitis in one small joint. A small joint would be metacarpophalangeal joint or interphalangeal joint of the toe. And there should be 6 points of classification criteria. We'll look at the classification criteria because now we know that to be able to diagnose, there should be at least 1 small joint and 6 such criteria present to make a diagnosis of rheumatoid arthritis. Diagnosis is aided, but is not entirely dependent on positive serology and acute phase reactants such as CRP, ESR, anti-CCP antibodies. So it's the clinical grounds, finding of synovitis in 1 small joint, and there are 6 points of classification criteria, which we'll see in a second. If a patient at the time of diagnosis has erosions on the joint surfaces and a high increase of anti-CCP antibodies, the prognosis is poor. So what differential diagnosis do we include with the diagnosis of rheumatoid arthritis? Clearly, viral arthritis, including flu virus arthritis, and also small joints of the back. Reactive arthritis, which means is a reaction to trauma or infection or injuries, and it could involve large joints as well. Seronegative polyarthritis, by which one means that rheumatoid factor is negative. Polymyalgia rheumatica, which is a kind of a soft tissue disorder of the rheumatoid arthritis, affecting tendons, ligaments, muscles which support body weight. Septic arthritis sometimes appears in the same way and must be excluded as a matter of priority. There are some connective tissue disorders which mimic symptoms and sufferings of rheumatoid arthritis. There are other conditions such as thyroid cancer, multiple myeloma, infective endocarditis, acute rheumatic fever, sarcoidosis, and hemochromatosis. This is a big list of differential diagnosis. So we come back again to what parameters of symptoms and tests do we rely on in making the diagnosis of rheumatoid arthritis. Majority agree that disability assessment score in relation to 28 known joints which are especially involved is a good method. So DAS-28, which we'll define a little later on, is the main basis of making a diagnosis and how severe the rheumatoid arthritis is. So it is involved with initial diagnosis and monitoring of the patient's rheumatoid arthritis activity when the patient is under treatment. There is a visual analog scale of global health as well. So the patient themselves would estimate from 0 to 10 as to how their overall health is affected by their symptoms arising from rheumatoid arthritis. And that leads to a score as well. We have already mentioned about joints involved in the process, mainly the small joints, but also the large ones as well, and the levels of ESR or CRP. So how does one categorize the level of rheumatoid arthritis? When the overall calculation of the disease activity is more than 5.1, it is said to be high disease activity of rheumatoid arthritis. A little less, between 3.2 to 5.1, constitutes moderate disease in relation to how bad rheumatoid arthritis is. When rheumatoid arthritis is low, such as between 2.6 to 3.1, then often the outcome has been good in relation to allowing a remission to take place. Symptomatic remission also includes remission from lowering of these inflammatory parameters to less than 2.6. So all this looks a little confusing. So let's look at exactly what the disease activity score or disability activity score is. It's a measure which utilizes the number of tender and swollen joints in a 28 joint count, plus ESR and the CRP as to how high they are, plus the patient's estimate of general health on a visual scale. And it could be from 0 to 100, although 0 to 10 is the usual one used. And remission is present when the patient achieves a score below 2.6, as we have just mentioned in the earlier slide. So what calculations are made? So if one large joint is involved in the process of what seems to be rheumatoid arthritis, we don't score anything. 2 to 10 large joints, score 2. 1 to 3 small joints, 3. 4 to 10 small joints, 5. Similarly, negative rheumatoid factor and negative anti-CCP scores 0. Low rheumatoid factor or low anti-CCP will score 2. High positive rheumatoid factor and high positive anti-CCP will lead to 3. So if we make the calculation reach more than 6, the person has rheumatoid arthritis. So these are the 28 joints in consideration. Remember that the large number comes from the small joints, such as metacarpophalangeal joints, proximal interphalangeal joints, and the same would apply to the feet as well. And so these are large joints. So when we looked at, we also classify on the basis of inflammatory reactants. And so we've already mentioned that if the CRP is normal and the rheumatoid factor is negative, score 0. Abnormal CRP or ESR, whatever the number, it's 1. If the duration of symptoms have been less than 6 weeks, score 0. If the duration of symptoms have been more than 6 weeks, score 1. And so how does one monitor and score? Sorry, I thought it would be, and yes, it's beginning to open, I think. As you can see, the disease activity score, so you count how many joints are under consideration, which are swollen or tender. And then, of course, you calculate the level of ESR and CRP. And of course, you also then make the patient's global health self-assessment between 0 to 10 or 0 to 100, and they put a score there. And this leads to a calculation of what the category of the patient is in respect of how bad the rheumatoid arthritis is. So how does one treat rheumatoid arthritis? In the primary care, as soon as a clinical diagnosis is made, of rheumatoid arthritis, the patient should be immediately referred to the rheumatologist. The guidelines suggest that the primary care physician should refer within 3 days. That means even before the blood test results are available or x-rays are available. The entire idea is that the rheumatologist should be able to halt the progress of rheumatoid arthritis with some form of disease-modifying anti-rheumatic drugs. So there is urgency of referral on clinical grounds. But a national audit was undertaken of the response of the guidance given to the primary care. So this is National Early Inflammatory Arthritis Audit 3 years ago, which showed that despite all the guidance and information, only 47% patients were referred by the primary care within 3 days. That means 53% patients were not referred within 3 days. And when referred, then only 48% patients were reviewed by the specialist within 3 weeks. And so the system isn't working as it was expected. One would offer pain relief with non-steroidal anti-inflammatory drugs, such as ibuprofen, naproxen, Voltarol, paracetamol, cocodamol, which is a combination of codeine and paracetamol, or opioid medications such as tramadol, dihydrocodeine, or even morphine sulfate orally. Steroids should not be initiated in the primary care until the rheumatological assessment is completed, because it may mask symptoms and signs. The rheumatologist would aim to treat to target. What does that mean? It means that the score should go down to low, or it should go down to below 2.6. Again, the aim is to achieve clinical remission or laboratory remission or both. So how does one treat a patient with rheumatoid arthritis in the hospitals? One would treat the patient with glucocorticoids, which produce immediate change and benefit, such as using oral prednisolone or intra-articular joint injections of prednisolone-like substances. One could use conventional disease-modifying anti-rheumatic drugs, such as methotrexate, sulfasalazine, leflunomide, or hydroxychloroquine. There are some reservations, and therefore individual selection should be made. In addition, or as an alternative, biological and synthetic agents can be used and should be used. Tissue necrotic factor inhibitors, CD20 inhibitors, interleukin 6 inhibitors, JAK inhibitor, or CTLA4 inhibitors could be used. And of course, the list is long, and research luckily is going on, making some changes. There is therefore a choice of therapy for a good outcome to be achieved, which is to target. With the diagnosis of rheumatoid arthritis, there is a greater predilection of catching opportunistic infections. So pneumococcal vaccines, flu vaccines should be given, but not live virus vaccines such as shingles vaccine. There are some non-pharmacological therapies available as well, such as physiotherapy, occupational therapy, attention by podiatrists to the feet and joints, and psychological support. Looking at glucocorticoid, this works by binding to the glucocorticoid receptor in the cell nucleus, which means the cell nucleus will control deterioration of cellular functions as much as possible with the glucocorticoid support. And when cell is damaged, there are pro and anti-inflammatory proteins. As a result of blocking the receptor, such noxious chemicals do not harm the joint surfaces and the synovial membrane. And therefore, glucocorticoids can rapidly reduce inflammation. It's used initially or when treatment is moving on from conventional DMARD to biologics. So the bridging part is when glucocorticoid offers support. But they should not be continued for a long while. And it is generally observed that prednisolone more than 10 milligram per day for a month can lead to hypertension, impaired glucose tolerance, and even osteopenia and osteoporosis. So what does one mean by disease-modifying anti-rheumatic drugs? They're classified into conventional, biologic, or synthetic, as characterized by the prefixed symbols. They are the mainstay of the treatment. Main treatment is through DMARD. It reduces inflammation, slows down progression of rheumatoid arthritis, and of course, NICE gives guidance that clinicians should treat to target. And the clinical remission is when the disease activity score, as we discussed earlier, gets down to less than 2.6, or when the disease activity is significantly low, such as it is less than 3.2. So at this stage, either of clinical remission or low disease activity, the target has been reached. And of course, the conventional DMARD include, as we've mentioned before, methotrexate, sulfasalazine, leflunomide, hydroxychloroquine, and others are being added. This is a complex slide, and we'll see a better version where general features of each, such as methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine are compared. But looking at this individually, this has been the first line anchor treatment for rheumatoid arthritis. So this should be tried first. It inhibits dihydrofolate reductase, and therefore folic acid support need to be given. And it eventually leads to inhibition of inflammatory cells, precursors, such as T cells and B cells activation. And if such activation is reduced or blocked, then the challenges of rheumatoid arthritis substantially reduce. It's given usually orally, but when someone is intolerant, it will be given subcutaneously as well as once a week. And the dose selected for resolving the activity could be between 7.5 to 25 milligram. Because the 10 milligram tablet of methotrexate looked exactly like the 2.5 milligram, UK will only allow pharmacists to keep 2.5 milligram tablets. So they would need to take multiples of 2.5 milligram tablets once a week, initially 7.5, and then this is increased on a weekly basis to the usual maximum of 25 milligram once a week. And the side effects are related to GI tract, liver enzymes, pneumonitis, bone marrow suppression. Whilst anyone is on methotrexate, because the folate pathway is adversely affected, then folic acid 5 milligram is taken on a daily basis, but not on the day that methotrexate is administered. So patients would be taking folic acid 5 milligram one day after the methotrexate and stopping on the day that methotrexate is administered. Because it affects liver, so alcohol intake must be minimized. Pre-treatment chest X-ray is important to form a baseline as some patients develop pulmonary fibrosis and other restrictive disorders of the lungs. Methotrexate is highly teratogenic, so it's completely disallowed in pregnancy or when one intends to have a child. There are alternatives. Sulfasalazine is an old-fashioned medication which had been around as a prodrug for quite some time. And so it breaks down in the gut into sulfapyridine and 5-amino-salicylic acid. It is this aspect which is an inhibitor of the pro-inflammatory cellular pathway activation. So sulfasalazine stops inflammatory process. It cannot be used when someone has allergy to aspirin and to sulfonamide. Side effects are nausea, vomiting, blood dyscrasia, and unlike many other DMARDs, it is safe to use in breastfeeding and in pregnancy because it's not teratogenic. And once someone is on sulfasalazine, one would monitor full blood count, urea, and LFT. And this is the monitoring used for methotrexate as well. Leflunomide. This is given at a dose of 10 to 20 milligrams once a day. It's usually a second-line agent, but when a patient is intolerant to methotrexate and sulfasalazine, then it can be used as a monotherapy. Otherwise, it's used in combination with something else. It inhibits the synthesis of pyrimidine. And so pyrimidine is linked to the development and proliferation of lymphocytes. And therefore, this works by reducing the impact of rheumatoid arthritis. Side effects are similar to methotrexate, but leflunomide can cause malignant hypertension and blood dyscrasias, and it is like methotrexate, highly teratogenic. It interacts with warfarin, and warfarin works for a longer time, so more frequent INR and lowering the dose of warfarin is necessary. Hydroxychloroquine has been an anti-malarial, but with mild immunosuppressive effect. It's a second-line agent and used mainly with conventional DMARD of another type. But in very rare conditions, it can be used as a monotherapy on its own. And the dose is 5 milligrams per kilogram body weight. Its main side effect is retinopathy. So it is customary to arrange for OCT from an optometrist or an optician to make sure that there is no pre-existing retinopathy. The adverse effects and side effects include concurrent use of tamoxifen for breast cancer, renal impairment such as CKD, and it does interfere with their absorptions and also causes renal impairment, particularly if the dose is higher than 5 milligrams per kilogram. This is the only conventional DMRD where blood monitoring is not considered necessary, and it's safe with pregnancy, lactation, and with warfarin. Briefly, I will mention that there are many biological and synthetic agents available now. They are usually monoclonal antibodies or fusion antibodies. Suffice it to say, they work exactly like the COVID-19 vaccines, that they block the cellular receptor sites. So therefore, rheumatoid arthritis activation is minimized, and there are fewer trigger factors, and there's no receptor for the trigger factors or causative agents to work on the cells. NICE has approved some of these, particularly when the disease activity is between 3.2 to 5.1. If this low level persists, then one can use the biologics. And for them to continue to use it on a maintenance basis, there should be a score less than 1.2 at 6 months of DAS28. Because these are expensive, so there are guidelines justifying continuing use. The biologics include tissue necrosis factor inhibitors, and that was the first biological agent. They neutralize TNF alpha molecules, and in the UK, etanercept, infliximab, certolizumab, pegol, adalimumab, Humira, and golimumab are licensed for use, usually in combination with methotrexate. But adalimumab, which is Humira, etanercept, and certolizumab, pegol, can be used as monotherapy. These are usually subcutaneous or intravenous injections in the form of infusion with saline. And because they can activate latent and inherent and dormant infections, patients are screened for TB, HIV, hepatitis B and C. They do increase the infection risk. Rituximab is usually used when anti-TNF have not been helpful. It's a monoclonal antibody targeting the CD20 protein, which it inhibits. It's administered by IV infusion once every 6 months and is used as a supporting medication with methotrexate and IV glucocorticoids. It increases latent infections, and it is contraindicated in cardiovascular disease. Abatacept. This is a CTLA4 domain fusion protein, so it blocks the receptors completely. So it prevents activation of T cells, can be given intravenously or subcutaneously. It's a new product. JAK inhibitors, Janus kinase inhibitors. This is the most recent class of anti-rheumatic drugs licensed at the moment in the UK. They are orally administered, and they are licensed as baricitinib, upadacitinib, tofacitinib, and filgotinib. And it's this one which is used more often. Again, the side effects are nearly the same as the other biologics. Interleukin-6 inhibitors, the varieties are tocilizumab and sarilumab. It inhibits joint destruction, and it reduces osteoclastic activity. So it works in the worst form of rheumatoid arthritis. It is generally not used for the minor versions of rheumatoid arthritis. And because it stops the development of CRP, the inflammatory marker is artificially lowered. So finding of low CRP is not a measure of improvement of the condition, but blockage from the interleukin-6 inhibitor. So what does one use? Obviously, it's a question of the preference and of the rheumatologist and response in the patients. It is expected that in the future, histological and genetic information may be readily available in making a decision as to which patient would respond better with which brand of treatment. A recent trial, when TNF inhibitors have failed, that tocilizumab is a more effective treatment than rituximab, but personal approaches are necessary. I hope sincerely that I have not confused the audience of the biologics and other measures of treatment and control of rheumatoid arthritis. Thank you very much for listening.